So this kind of feels like a topic I've done on my channel, but I actually went through the channel and realized I didn't do a topic on gestational diabetes. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at gestational diabetes mellitus. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be getting notifications of such videos every time I post. Grab your piece of paper, grab your pen, and let's jump right in. So remember from our lecture in diabetes mellitus in internal medicine, we defined it as a chronic metabolic disorder where you're going to be having either insulin deficiency, which may be relative or absolute. Relative in terms of type 2 diabetes, absolute in terms of type 1 diabetes, coupled with sometimes peripheral tissue resistance. That's a decreased sensitivity to insulin that's often seen in type 2 diabetes. Lastly, we divided it into two main types. Type 1, which was formerly known as insulin-dependent diabetes mellitus because these have an absolute insulin deficiency. It's much more common in the young individuals, so it's the juvenile type, and individuals are much more slim as compared to their other counterparts that have type 2 diabetes. This has a genetic predisposition and also is going to be characterized by the presence of autoantibodies. Then you also have type 2 diabetes mellitus, which is of late age onset. And of course, most of these patients are going to be on the larger side of life. They also do have some peripheral tissue resistance to insulin. And remember that the peripheral tissues are pretty much your skeletal muscles, your liver, and your adipose tissue. There is also a genetic predisposition that's seen with type 2 diabetes. We're not going to be focusing much on type 1 and type 2 diabetes in this case, but I will allude to it a bit later on towards the management of the condition, because you may have some patients that already have pre-existing type 1 or type 2 diabetes that eventually fall pregnant, and you actually have to manage them during the pregnancy, before the pregnancy, and after the pregnancy. So when you talk about gestational diabetes mellitus or GDM, this is pretty much someone who has the onset of diabetes or the appearance of an abnormal glucose tolerance for the first time. Keynote, for the first time during pregnancy. Ideally, it's after 20 weeks of gestation. And remember, the key word here is persistent. So a persistent rise in the blood sugar, a persistent abnormality in the glucose tolerance for the first time in the pregnancy after 20 weeks. If they had it before the pregnancy, then this is known as pre-existing or pre-gestational diabetes mellitus. So remember that gestational diabetes mellitus is pretty much going to be much more common in the second half of pregnancy, particularly in the third trimester, because as we go further and further during pregnancy, the insulin resistance is going to increase, and also there's going to be a slight deterioration in glucose tolerance. Remember that about 5% of the pregnancies are going to develop GDM, but the rates are higher in other specific groups like Mexicans, Americans, American Indians, Asians, Indians, and even Pacific Islanders. And remember that a small proportion of these women that actually do develop gestational diabetes mellitus are going to remain diabetic afterwards, after they deliver, because the essence here is that after someone develops gestational diabetes, once the pregnancy has gone, you expect them to revert back to normal. But a small proportion actually continue and become diabetic and they have overt diabetes. Some actually revert back to normal, which is why the name pregnancy-induced glucose intolerance has been suggested by some literature. So remember that if the glucose readings after delivery, after 6 to 12 weeks, normalize, then in retrospect, that woman surely did have gestational diabetes. However, if the glucose readings do not normalize or they remain elevated past 12 weeks, then you have a retrospective diagnosis of diabetes, which is pretty much either type 1 or type 2, depending on whatever you have. And remember that if someone has pre-existing diabetes mellitus, whether it be type 1 or type 2, this is not going to be, it hasn't been shown to actually exacerbate diabetic retinopathy if they have any pre-existing, any nephropathy or any neuropathy, as opposed to what most people think it may. So women with gestational diabetes mellitus are actually at risk of developing type 2 diabetes in the future, so they must be followed up closely postpartum. So what are some of the WHO definitions of DM in general? So this is a fasting blood glucose greater than 7, a random blood glucose greater than 11.1. Let me just give you some perspective of what fasting blood glucose and random blood glucose is in case you're tackling this for the very first time and you haven't watched the video in internal medicine. So fasting blood glucose is pretty much the glucose that you check after someone fasts, doesn't eat for a period of about 8 hours. So let's say someone doesn't eat after 20 hours the previous night. Then in the morning at 6 hours, you check their blood glucose. You call that as your fasting blood glucose. So if it's greater than 7, you already have some suspicion that this could be diabetes. And remember, the key is persistent, not just one reading that's greater than 7 and you say that a patient is diabetic. No, you have to have some persistence. Then the random blood sugar is the blood sugar that you checked regardless of whether the person has eaten or they haven't. Generally, a random blood glucose that's greater than 11.1 is considered diabetic. And remember, in non-pregnant women, you're going to need symptoms plus either an abnormal fasting or an abnormal random glucose test or an abnormal glucose tolerance test. If they don't have symptoms, then you need all three of them. So you can sometimes perform a glucose tolerance test, which is 2 hours, where you can give them either 75 to 100 grams of oral glucose load. Then you check their blood glucose at 1 hour, actually at 30 minutes, at 1 hour, at 2 hours. And then if those readings, especially the ones at 2 hours, are greater than 11.1, then you're considering them to have diabetes. Remember that we can also do a 2-hour glucose tolerance test, and the significance of it being impaired, meaning having a value between 7 to 11.1 in pregnant women, has been debated for quite some time. So generally, the general consensus right now is that even though some people initially thought that it may have some bad effects on the pregnancy, actually doing this test has no detrimental outcome on the pregnancy, unless if the WHO criteria for diabetes is actually reached. And remember that pregnant women with diabetes, whether it's pre-gestational, whether it's gestational, are going to be at a much higher risk of developing perinatal morbidity as well as perinatal mortality. There is something that's known as White's classification of pregnant diabetic women. This is very important, especially for the final year students. So we divide them into different classes. As you shall see, I shall mention some of these classes along the way, especially when you talk about the management. So there's class A, B, C, D, E, F, R, and T. So the first column here is on onset, the fasting plasma glucose, the 2-hour postprandial glucose, and of course the treatment. So those that are at type A or class A, any age. It's further subdivided into A1 and A2. A1 is a glucose level less than 105 milligrams per deciliter. A2 greater than 105 milligrams per deciliter. In a 2-hour postprandial, you have those values there. So you treat them with diet as well as insulin. So here, as you can see, the readings that have been given here in milligrams per deciliter, but we don't use that in our setting here in Zambia. We're going to be using millimoles per liter. So you can actually divide that by a factor of 18. Then class B are those that are above 20 years with a duration that's less than 10 years. They don't have any vascular disease. And of course, the treatment is giving them insulin. So as you can see, most of the times, the key drug that you're going to be giving these diabetic patients in pregnancy is obviously your insulin. So just take your time. You can get a screenshot of this. You don't have to memorize this. No one is expecting you to know this, but of course, just know the highlights from this White's criteria of classification of pregnant women with diabetes. There are some risk factors that are associated with gestational diabetes mellitus: obesity, those that have a body mass index or a BMI greater than 30 kilograms per square meter, and age greater than 30, certain ethnic groups like Eastern Asians, Pacific Island ancestry, then those that have a family history of diabetes, whether be it a parent or a sibling. Those that have a family history should also include things like aunties, uncles, even grandparents. Those that have a previous history of giving birth to a large baby, a fetal macrosomia, which is actually greater than 4.5 kg. Then, of course, a previously unexplained stillbirth with, of course, pancreatic islet hyperplasia that's revealed on autopsy of the dead child. Then if they have unexplained perinatal losses, previous congenital abnormalities that we shall allude to towards the end of this lecture, a previous traumatic delivery, all these are risk factors for gestational diabetes. And these are very important because once you identify some of these risk factors, you do have to screen these women for gestational diabetes. So how do we do the screening? So the screening is ideally done at 24 to 28 weeks, and there is a two groups of thought. So there is those that believe that every single woman that is pregnant should actually be screened for gestational diabetes. Then there's another school of thought where they believe that screening should be done to those patients that are at potential risk, those that are either average risk or high risk. So we divide them into three main groups. Of the low risk, those that do not have any of the risk factors that I've mentioned on the previous slide, the blood glucose testing is not routinely done for these patients. Then those that have an average risk, they have some of the risk factors that are present, so you should perform the screening tests. Then of course, those that are at high risk, have many of those risk factors, then you should perform blood tests as soon as possible. So how do we screen for this patient? So there are two ways in which we do this. So there is the two-step screening, or we can do the one-step screening. So some obstetricians actually advocate for doing the one-step screening, which is a 2-hour postprandial glucose tolerance test. Though it's not commonly done, even this two-step screening test in our setting is not commonly done. So there are two steps that are usually done. So there is step 1, where you're going to be giving this person 50 grams of oral glucose. So you call this as a 1 hour 50 gram oral glucose challenge test. So regardless of the time of day, regardless whether they're fasted or whether they've eaten or not, you give them 50 grams of glucose, oral glucose. This test should actually be done between 24 to 28 weeks of pregnancy. So once you measure the blood glucose at 1 hour, and if you find out that it's greater than 7.2 to 7.8, then you consider this as positive. Then you move on to step 2. If it's less than this, there's no need to move on to step 2. Unless if you have a high index of suspicion that this woman could have gestational diabetes, you may repeat the test on another day. So after you have confirmed this with step 1, you move on to step 2, where now you're going to be giving them a 3-hour 100 gram oral glucose tolerance test. So here the patient should fast. So they should fast for about the previous night, let's say from 20 hours the previous night, and then at 6 hours, you pretty much are going to be checking the fasting blood glucose before they take the 100 grams of glucose. Then once they take the 100 grams of glucose, you check the blood glucose at 1 hour, at 2 hours, and at 3 hours. So if the fasting blood glucose is greater than 5.3 millimoles, you consider this as a positive test. If at 1 hour it's greater than 10, you consider it as positive. If at 2 hours it's greater than 8.6, you consider this as positive. If at 3 hours it's greater than 7.8, you consider this as a significant reading, positive. So we make a diagnosis of gestational diabetes if any of these two values are above or are equal to the set limits that I've put on the screen. Then if the fasting blood glucose is already initially greater than 7, there is even no need to do that same oral glucose tolerance test because the patient already has overt diabetes. Now, what's the pathophysiology of the condition? So there is one important hormone that I want you to remember. This is known as human placental lactogen. So remember, human placental lactogen is very important because the fetus needs glucose. And remember that the organs in the fetus are not yet so well developed. The liver isn't yet so well developed to actually store that much glycogen, to actually metabolize the glucose. So the fetus will largely depend on the glucose that's coming from the mother. So there are some significant changes that are going to be happening in the mother that are going to be affecting carbohydrate metabolism during pregnancy. And remember that for this glucose to actually be channeled, remember that glucose in pregnancy, the placenta doesn't have any, the receptors that are found in the placenta are not insulin dependent. They do not depend on insulin for glucose to diffuse from the mother to the fetus. The diffusion is actually based just on facilitated diffusion. So it means that the blood glucose levels in the fetus are going to be matching quite similar to the blood glucose level in the mother. So if the blood glucose level in the mother are elevated, you would expect that the blood glucose level in the fetus is also going to be elevated. Keep this in mind. And remember, human placental lactogen is what's also helping the placenta have a bit of some affinity to get some of these glucose from the mother to the fetus. So you have this increase in this amount of human placental lactogen and cortisol, and these two hormones are pretty much diabetogenic. So they are insulin antagonists. So once the levels of these hormones actually increase as the pregnancy goes further and further, especially most marked in the third trimester, this is going to decrease the sensitivity of the peripheral tissues towards insulin, such that now the mother's peripheral tissues will not be responding so well to the insulin. And this is of course heightened in, the response is heightened in gestational diabetes mellitus, such that in pregnancy, this person is going to be having a much higher rise in the blood glucose levels than usual. Remember, this is not supposed to happen because typically in a normal pregnancy, there's supposed to be a fall in the levels of glucose because most of the glucose is going to be used for carbohydrate metabolism, because as the pregnancy is going further and further, even the demands for energy are also increasing. Even at certain stages of pregnancy, the demands for the energy are also increasing. So remember that the fetal glucose levels must also be monitored very closely and be kept within narrow limits of the mothers. So the ideal thing here is that to keep this in mind, once you control the mother's blood glucose levels, you pretty much control the fetus's blood glucose levels. Why is this important? It's very important, especially in the early trimesters. What I've seen is this: with patients that have pre-gestational diabetes that's uncontrolled, they are at higher risk of developing fetal malformations than those that have, or those that develop gestational diabetes. Actually, with gestational diabetes, it hasn't been significantly associated with these congenital abnormalities as opposed to pre-gestational diabetes. So it's very important that you must actually control the levels of glucose in the mother before she actually decides to fall pregnant, before she decides to conceive. So what are we doing in our setting? So in our setting, we're going to be sending for a fasting blood glucose. We're also going to be sending for random blood sugar. So a random blood sugar greater than 11.1 is pretty suspicious for diabetes. A fasting blood glucose greater than 7 is suspicious for diabetes. If you have a fasting blood glucose greater than 7 on 2 separate occasions, or a fasting blood glucose greater than 11 on any one given occasion, and no oral glucose tolerance test is going to be needed. So we often send blood for glucose tolerance testing at 24 to 28 weeks. Like I said, we tell the woman to fast at least 8 hours before. We draw the blood to check the fasting blood glucose. Then the woman drinks about 75 grams of glucose in about 300 mils of water. Then the serum glucose is measured at 1 hour, then 2 hours. So normally, the fasting blood glucose should be less than 5.6. The 2-hour post glucose should be less than 7.8. Then if it's impaired, the fasting blood glucose is between 5.5 to 7. The 2-hour postprandial glucose, so 2-hour the post glucose tolerance test, it should be 7.8 to 11.1. If their fasting blood glucose is greater than 7, the 2-hour blood glucose test is greater than 11.1, then they are considered as diabetic. So there is a rules of 15 in gestational diabetes mellitus. So 15% of gravidas have a positive 1-hour glucose tolerance test. 15% of the positive cases are going to develop gestational diabetes mellitus. Then 50% of those that develop gestational diabetes mellitus are going to need insulin. The rest are actually going to be benefiting only from dietary modifications. Now, what are some of the effects of gestational diabetes? When it comes to obstetrics and gynecology, it's very nice to actually group complications, effects into different compartments. It's very easier to present, it's very easier to remember. So you can actually divide the complications into maternal and fetal. Maternal can be further subdivided into antenatal, intrapartum, postpartum. So what are some of the antenatal maternal effects? So there's a 4 times risk of increase in pre-eclampsia. There's an increased risk of bacterial infections, UTIs, and even vulvovaginitis because of the impaired immune response due to the hyperglycemia, and also due to the high blood glucose. It provides a nidus for infections. Then there is also an increased risk of polyhydramnios. This is very important, and I want you to listen to this pathophysiology. So remember that in someone who is diabetic, a pregnant mother that's diabetic, this pregnant mother is going to be having high levels of insulin, high levels of glucose. So most of this glucose is going to be channeled to the fetus, the developing fetus inside the uterus, and the fetus is also going to be having large amounts of glucose. So it means that generally even the size of the baby is going to be much larger, the placenta is going to be much larger. And remember that once you get these high levels of glucose in the fetus, this glucose is also going to be filtered out by the kidneys in the fetus. And remember that the kidneys, the amniotic fluid is pretty much the majority of it towards the last term of pregnancy are pretty much going to be as a result of the urine that the fetus is producing. So it means that because you have a high levels of fetal blood glucose, it's going to filter out into the kidneys. The child is going to urinate a lot, so the child will have polyuria, and of course this will increase the amount of the liquor in the uterus, and then this is also going to be causing polyhydramnios. Then also some of the glucose that's present in the liquor is going to also be irritating the amniotic epithelium, and this is going to also increase osmosis. There is also maternal stress due to the increase in size of the fetus, the fetal macrosomia, even the polyhydramnios. There's an increased risk of preterm labor, which is seen with polyhydramnios and even a large baby. And there is also a risk of ketoacidosis. I'll do a separate video of the management and approach to diabetic ketoacidosis in pregnancy. Then intrapartum, what are some of the effects? There may be prolonged labor due to a big baby, shoulder dystocia, where the fetus's shoulder is impacted on the maternal pelvis. This is obviously due to this disproportionate growth and increase in shoulder to head ratio. You may also have some perineal injuries. You may have a higher rates of operative delivery. Postpartum effects are going to include things like postpartum hemorrhage, puerperosepsis, and even lactational failure. Now, what are some of the fetal effects? So the fetal effects, there is an increased risk in perinatal mortality. It's greater with those that are White's class A2 than those that are White's class A. There is a 2 to 3 times risk of increased preterm delivery. And remember, the hyperinsulinemia, the hypoglycemia is leading to fetal macrosomia, because remember, insulin is an anabolic hormone. This is going to be pretty much causing birth injuries, such as the shoulder dystocia. They may have hypoglycemia, which tends to affect most of the fetal organs except the brain. They may have excessive fat that is present on the shoulders and the trunk. They may have some metabolic derangements at birth. Hypoglycemia, hypocalcemia. The hypoglycemia is because of this. Because this child has a high level of glucose in their body, they're going to keep making high levels of insulin. So this child will also have high levels of insulin in the body, such that when they are born and they're no longer receiving this support from the mother, if they're not fed immediately, then the insulin that is present, the high levels of the insulin that is present in the child will use up the glucose that is present, and this child can easily tip into hypoglycemia. So you have to involve the pediatricians during the birth of a child of a diabetic mother, because there is a risk of hypoglycemia. There is a risk of hypocalcemia due to immature development of the parathyroid gland. What are some of the major birth defects that are seen in infants of diabetic mothers? We can group them into systems. So in the central nervous system and skeletal system, you may have neurotube defects, anencephaly, microcephaly, caudal regression syndrome, and sacral agenesis. In the cardiovascular system, you may have VSDs, ASDs, coarctation of the aorta, transposition of the great vessels, situs inversus, where most of the organs are switched, like the left side is now on the right side and the right side is on the left side. A tetralogy of Fallot. On the GIT, you may have duodenal-atresia, anorectal atresia, omphalocele, tracheoesophageal fistulas. In the renal system, you may have renal agenesis, hydronephrosis, double ureters, and polycystic kidneys. Then you may also have a single umbilical cord artery. It's very important that you check for the umbilical cord to see if they have the arteries, and of course the two arteries and the vein. Then you have good glycemic control in preconception counseling actually reduces the incidence of the risk by 0.8 to 2%. And remember that these major defects are seen in 6 to 10% of mothers that are diabetic. Remember that poor control of pre-existing pre-gestational diabetes, especially during organogenesis, up to 10 weeks, is going to increase the risk of these fetal anomalies. And the fetal anomalies are not increased by gestational diabetes. This is a very, very key point. Gestational diabetes does not necessarily increase the risk of fetal anomalies. It's seen with pre-existing diabetes rather. Then you may have recurrency of gestational diabetes in the subsequent pregnancy up to about 50%. Now, how do we manage these patients? What are the principles? So number one, we want to actually have antenatal supervision, strict glycemic control, so that you maintain the levels of glucose and you maintain them near physiological place as much as possible. You want to actually find the optimal time and the method of delivery. We'll talk about that. You want to arrange for the care of the newborn, and you want to manage any complications that may arise during, or actually before the pregnancy, during the pregnancy, and after the pregnancy. So what's our initial management? So preconception counseling, very important. So for anyone that's planning on getting pregnant, and if you're a diabetic, go get checked. Make sure that your blood glucose, before you actually even conceive the child, make sure that everything is in control. Your HbA1c is within the normal range, or rather the ideal range. The glucose readings are also within the ideal range before the conception. Then as soon as you actually conceive the child, you should actually go to the hospital. And remember that the frequency of the visits that you have in the antenatal period are largely dependent on how well your glucose is controlled and whether certain complications are present or they are not. So the antenatal supervision should be done monthly, in monthly intervals up until 20 weeks. Then after, you can do it 2 weekly. Then as you reach towards where you plan to develop, or when you plan to deliver the child, you can actually do them weekly. So the trial of diet and exercise, walking, can be done for 2 to 4 weeks, especially for those that are rather obese, those that have a BMI greater than 27. Then nutritional counseling, you should advise them to take complex carbohydrates. So they should avoid simple things like sweets, candy, honey, cakes, because those tend to have a wide variation in the blood glucose. Then you should send blood for the full blood count, and then of course advise them to actually get a glucometer, such they should be checking their fasting blood glucose at least twice weekly, recording it in a book. Then of course we treat them with oral hypoglycemic agents if their fasting blood glucose is greater than 8 millimoles on 2 or more separate occasions. So way back, we weren't really using these drugs, especially in pregnant women, but now recent studies have shown that they are actually safe to be used in pregnancy. Insulin can also be used. Insulin is actually the drug of choice, but these hypoglycemic agents are becoming more common because you can administer them orally. They are much cheaper than the insulin to actually acquire. So glyburide is the drug that I've seen that can be used. Metformin is not used in pregnancy. So glyburide at 2.5 milligrams orally twice a day, then you increase it weekly to a maximum of 20 milligrams daily. We may consider the glibenclamide. That's if the Royal College of Obstetrics and Gynecology actually recommends, but the recommendation is with glyburide. Then you should check your fasting blood glucose, and you should be checking it twice weekly with a glucometer. Then of course we switch to insulin if they are fasting blood glucose, despite you having the diet and exercise and starting them on the glyburide, and it's still not working. After the blood glucose is still persistent for greater than 8 millimoles, we switch them to insulin. Then after they give birth, after 12 weeks postnatal, we should actually send them to the medical clinic where they can be followed up because there's a risk of long-term diabetes. So let's talk a little bit about insulin. So remember that for those that are pre-gestational, they should continue their pre-pregnancy regimen. If their blood glucose is controlled, they should continue it. If it's not, consult the physicians so that they can actually come in and control this person's blood glucose levels. So for the women that have never used a glucometer before, you should consider admitting them for the patient education. Of course, we do not do this in our setting. We can't admit someone just for patient education. We would actually teach them on the spot and send them home. So the antenatal visits should be done every 2 weeks until 30 weeks gestation, then weekly until delivery. So the American Diabetic Association diet should be followed, about 30 to 35 kilocalories per day, and we increase the calories for the normal glycemic ketonuria. Then we monitor the blood glucose at least 4 times. So it's 7 hours. We usually do it at 6 hours, 11 hours, 16 hours, and 21 hours. And remember, the insulin requirements actually vary during different trimesters. So in the first trimester is about 0.7, in the second trimester 0.8, in the third trimester 0.9 to about 1 international units per kg. And after the person delivers, the requirements actually reduce by up to even 50%. So we calculate the total dose that the patient is going to be needing. Then in the morning, we can divide it into 2 doses. The dose that you're going to give in the morning and the doses that you're going to be giving at night. Sometimes you can use the basal bolus regimen where you give a long-acting at night with the short-acting during the day at breakfast, lunch, and supper. That works as well. So from the total dose that you have calculated, 2/3 of it will be given in the morning. From this 2/3 that is given, 2/3 will be long-acting. You can give it as neutral protamine hagidone or NPH. 1/3 can be given as soluble insulin. Then 1/3 is given at night. So half of it is soluble, half of it is long acting. Let me give you a practical example. Suppose someone is 50 kilograms, right? 50 kilograms, and they're in the 3rd trimester. Let's say we use 0.9 international units per kg as their total requirements for insulin. So it means that in a day, they require about 45 international units of insulin. So 2/3 of 45 will give you 30 international units. So this 30 international units is a total that should be given in the morning. Then the remaining 15 international units should be given at night. So out of this 30 international units, 2/3 of it, which is 20 international units, is given as long acting. Then 1/3 of it, which is 10 international units, is given as soluble insulin. This should be given and the patient should actually be eating. Then at night, the 15 international units can be divided as 7.5 units. Just like that. So the goal is to get the fasting blood glucose to less than 6 millimoles, and the other blood glucose levels should be between 6 to 8. Then when you're adjusting the insulin, you want to achieve the blood glucose levels. Remember that 1 unit of insulin is going to be changing the blood glucose by approximately about 1 millimole per liter. So this is how we do the changes. So if here on this column here is your fasting blood glucose, here you have your random blood glucose. So if it's less than 4, we decrease the insulin by 4 units, because you can tip this patient into hypoglycemia. So I think this table is very self-explanatory, and this is when, to give you an idea, for example, if the sugar that you check at 7 hours is the one that's elevated, it means that the one that you should adjust is the evening dose, the long-acting evening dose. If the one at 11 is elevated, then the one that you should change is the morning soluble dose. If the one that's at 16 hours is deranged, the morning long-acting dose should be changed. If the one that's at 21 hours is changed, the evening soluble dose should be changed. So this should be self-explanatory. If you do not understand, please drop a comment in the section below. Do not forget to subscribe to the channel. Hit the bell notification icon to be receiving notifications of such amazing content. So what about the delivery? So in uncomplicated cases, we admit the patient at 34 to 36 weeks. 50% of the diabetic mothers are going to be delivered via C-section, but some of them are going to be delivered via the normal vaginal delivery if they do not have any contraindication to normal vaginal delivery. So indications for induction of labor include a diabetic mother with well-controlled blood glucose, and of course with on insulin for gestational diabetes mellitus or class B diabetes, and these are considered for induction of labor roughly at around 38 weeks of gestation. If they have any vascular complications like pre-eclampsia, intrauterine growth restriction, then we do deliver them, we induct them after 37 weeks. There are some indications for C-section, for example, fetal macrosomia, elderly prime gravidas, multigravida with bad obstetric history, diabetes with complications or difficulty to control, obstetric complications like pre-eclampsia, polyhydramnios, malpresentations. Then there is a place for awaiting for spontaneous labor to start, especially in the young primigravidas or the multiparous women with a good past obstetric history, diabetes who have well-controlled blood glucose, whether they are using diet or insulin, and if they have no other contraindication for any obstetric complication. Then in the absence of any gadgets to assess the fetal well-being, it's actually risky to continue the pregnancy up to the expected date of delivery. So in any case, the pregnancy should never be allowed to actually exceed the expected date of delivery. In the postpartum period, when you have just immediately delivered this child, clamp the cord immediately. This is going to prevent hypervolemia. So you can also perform, or actually not you can, you should perform active management of the 3rd stage of labor. Give them oxytocin after delivery of the anterior shoulder, 10 international units, followed by an infusion. Controlled cord traction, then of course examination of the placenta. So the placenta is often large, the cord is going to be thick. There may sometimes be a single umbilical artery. Remember that the normal umbilical cord should have 2 arteries and a vein. So after that, you should care for the child. Remember, the pediatricians should be involved. Asphyxia should be anticipated, so you treat them effectively. Look for any congenital malformations. Have the glucose checked within 2 hours of birth so that you avoid hypoglycemia. Or the baby should receive 1 milligram of vitamin K intramuscularly. Then, of course, early feeding is advocated for between 30 minutes to an hour of delivery, and then you repeat it at 3 to 4 hourly intervals, as this will reduce hypoglycemia, and it will also reduce the chances of hyperbilirubinemia. Then in the puerperal period, breastfeeding of the infant and notification of the pediatricians of the maternal diabetes should be done. Antibiotics can be given. Then, of course, the insulin requirements are going to be drastically falling. Remember, I told you that they may actually be less than 50% of whatever they were requiring during pregnancy. So it should revert them back to the regimen that they had before they fell pregnant. So a fresh blood glucose level after 24 hours will help you actually adjust the dose of the insulin. So we should use the sliding scale for about 5 days post-vaginal delivery and then resume the pre-pregnancy regimen afterwards. We treat them with DNS at 3 liters daily post C-section until they're able to tolerate oral feeds, and then we use insulin sliding scale. This is where you check the blood glucose, and if it's at a certain level, you give this amount of insulin, and here are the values and the amount of insulin that is given. Then we encourage them to breastfeed. Then, of course, in those that are lactating, we give them a lower dose of insulin. Then what about type 1 and type 2 diabetes? Those that have type 1 and type 2 diabetes in pregnancy. This I'm just going to be focusing on the management because I've already talked about type 1 and type 2 diabetes in greater details in another video. So I'll leave it tagged at the end of this video. So you want strict control, whether it's type 1 or type 2, strict control. You want the levels of the HbA1c to be equal or less than 6.5. You encourage those that have type 2 diabetes to lose weight, especially those that have a BMI greater than 27. We can do certain tests. So we should do a 24-hour urine collection to check for any proteinuria or the amount of excretion of creatinine. If we don't want to do this, right now the world is currently leaning towards doing a spot urine protein to creatinine ratio. This can help us check for any renal complications or significant proteinuria. We perform an ophthalmological examination to check for any retinal complications. We do an ECG to check for any cardiac complications. In the prenatal period, remember that we should recognize the pregnancy early, especially in diabetics, and we should actually encourage them to come for antenatal visits. The number of visits is never fixed. It should be individualized and should be dependent on the glycemic control. According to the American Diabetic Association guidelines, we should actually put them in an individualized diet in coordination with insulin administration. So a good rule of thumb is 3 meals and 3 snacks per day. And the emphasis here is eating at a consistent time. You should also educate these patients on the caution of hypoglycemia, especially during exercise and at night with those that are type 2 diabetic patients. And we should also actually teach their family on how to administer glucagon. Then we should check hemoglobin A1c every trimester. And then from 32 weeks up until delivery, or even earlier if it's indicated, we do a non-stress test weekly, a biophysical profile weekly, and we do kick charts or kick counts daily. Then the insulin regimen, of course, you calculate your total dose depending on the trimester they are in. Then, of course, 2/3 should be given in the morning. This is going to be 60% NPH, 40% regular insulin. Then at night, you give a 1/3 of the total dose, 50% of NPH, 50% of the regular insulin. And remember that the women that are taking can also be put on the long-acting insulin once or twice in combination with the insulin aspart, the short-acting insulin. This is like the basal bolus regimen at breakfast, at lunch, and at supper. And then those that are type 2 diabetics, those that are obese, should be put on short-acting insulin that they should take before each meal. Then in the intrapartum management, remember vaginal delivery at term, if possible. If you have documented the dating criteria and it's matching and the sugars are well controlled, amniocentesis is not done unless if it's an indication or if the couple actually requests for it. Then C-section should be done for obstetrics indications like macrosomia, because there's a risk of shoulder dystocia. There should be a constant low-dose insulin infusion which should be used, and this is preferred to a subcutaneous dose, so we should stop the subcutaneous. But if we plan on inducting the patient, induction of labor, we should give our evening dose of long-acting insulin, our NPH insulin, and we continue with the postpartum diabetic care after you have given pregnancy. And remember, after the pregnancy, the requirements fall to by up to 50%. Then here's a practical guide. So remember that you should get a comprehensive ultrasound at 18 to 20 weeks of gestation to screen for any fetal structural defects. Baseline maternal ophthalmological examination should be done for diabetic retinopathy. Get your baselines for your creatinine, for your diabetic nephropathy and renal disease. Send blood for MCS, the urine MCS, actually send urine for urine MCS rather, every trimester. Fetal surveillance, your kick charts, your biophysical profiles at 34 weeks until weekly until delivery, or you can start at 28 weeks for those that are at class D or higher, or those that have IUGR or any coexisting comorbidities like hypertension. In the intrapartum period, there is no specific treatment if the labor is progressing normally and quickly. Those that are being inducted should be given, of course, the evening dose of the insulin. The soluble insulin should be given as well, 1 liter of DNS, and you titrate it at 40 drops per minute. For those that are having the C-section, we should skip the morning dose of insulin and we start them on DNS. Then we place oxytocin in a separate bag of normal saline, and this should be actually infused separately. Then delivery should be at 39 weeks of gestation for all the women that have well-controlled blood glucose and no vascular disease, and it should be earlier for those that are at class D or higher, those that have polyhydramnios, macrosomia, poor glucose control, chronic hypertension, any medications, and then chronic hypertension on medication rather, and those that have intrauterine growth restriction that is seen often on ultrasound. I really hope you learned a lot concerning gestational diabetes. If you did, consider subscribing to the channel, hit the bell notification icon to be receiving notifications of such videos every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.